All right, let's talk wires and cannulation. Scott Weingart's going to help me with this, and we're going to throw little snippets of his pearls throughout this entire talk. You might be asking yourself, like, why do I need to know about wires? Well, there's really three kind of reasons that I think. One is I want you to sound educated when you're talking with your CT surgeon and your cardiologist. But I also think you're going to become a bit of a wire snob after you get into this a little bit, and I want you to be able to ask for that as quickly as possible. The third reason is I want you to avoid some of the mistakes that we've made where we've actually purchased whole bundles of the wrong types of wires. Diameter is pretty easy. There's a standard size, it's 0.035 inches. You're going to find this on your 9 French catheter. You're going to find this on the central venous catheter and arterial catheter that we use, and then mostly on the wires that you buy. Now the only caveat here is you just need to make sure you check when you're opening the package that that's the wire that you're using, and to check when you're buying these. All right, let's talk length. Length is a particularly important area. Now here you can see the typical 9 French catheter that has a 45 centimeter wire. Our 5 French Cook catheter has a 50 centimeter wire. When you lay these out, you can see that there's plenty of excess wire to deal with so that you have wire to hold on to at the end, but also to have wire that is inside the vessel. Now when we start putting out the larger catheters, when we put out our ECMO catheters, we can see that this is just not enough length for us to have sufficient amount inside the vessel as well as to hold on to as the outside. Now when we start talking about these longer wires, sometimes you can get very excessive. You can see that I'm putting this out next to my basketball court and it is huge. So you need to be cognizant that this may be going out the back of the room if you have long wires like this one, which will be 145 centimeters. And then your wires can actually get up to even as big as 260 centimeters. And so make the mistake that we did where we bought an entire package of 260 centimeter wires. You need to be cognizant that that will be probably problematic. Now there are even wires that go as high as 500 centimeters, and you can see me pushing one of these outside of our house. If you get one of those on accident, you're talking about going clear across the entire stratosphere. All right, let's talk tips and stiffness. When we're talking about tips, we're really talking about J-tip versus straight. When we're talking stiffness, we're talking about some of these Amplat super stiff wires that are very, very stiff. Now, I'll tell you, Scott and Joe both are in the camp that they like straight wires and they like super stiff wires. I'm a little bit different in the fact that I do like the soft wires just because I think it forces me to be gentle in the vessel. All right, let's hear from Scott. Teach us how to cannulate.
In an ideal world, the angle you would use to get from the skin into that common femoral artery would be as shallow as possible, because what you do not want to be is perpendicular, because then all of your subsequent dilation steps have to transverse that same 90-degree angle. That being said, a lot of times, especially in patients with a lot of adipose tissue, you'll really not be able to reach that artery with anything short of a harpoon at a nice shallow parallel to the vessel angle. So you do what you can, but ideally, the shallower the angle, the better, because it's easier to dilate a shallow angle approach from the skin to the vessel than not. If you had the foresight, you would have stuck something hard like a board or a CPR board behind the patient's butt so you straighten out the vessels and make it as easy as possible to get from skin to that vessel without having to use an angle. Okay. Do it wrong. But the idea is the wire should serve as the rail for the catheter, which is the actual monorail car. What am I talking about? Well, if you go to Disney or if you go to Japan, you know what I'm talking about. You have a train going on a rail, and in this case, it's a monorail. It's just a one rail. That rail never moves. The train moves over it, but the rail itself never moves. Same thing for this wire. The wire, as you are pushing dilators in and out or catheters in and out, never moves within the vessel. If the tip of that wire is at the level of the xiphoid within the aorta and you're putting a dilator over it, its tip remains at the level of the xiphoid, no matter what. No matter what. What doesn't happen is as you're pushing that dilator in, the wire doesn't move in as well, thereby moving up in the vessel. Or as you pull that dilator out, the wire does not move out of the vessel. The wire's tip stays in the same anatomical location no matter what, which means you always need to have one hand on the wire or the hand of an assistant on that wire, keeping it from moving in as you push that dilator in. Because otherwise, the natural move is as you push that dilator in, it will push the wire in. And now, instead of the tip of your dilator being retained in the circumferential center of that vessel, it could go wherever it wants since the wire is being allowed to move, and you could back wall that vessel and destroy it. So that is the key. If you're a single doc or a single interventionalist, you need to always have a hand on the wire and then a hand on the dilator or a hand on the catheter. If you have an assistant, it frees up a hand to do things like tauten the skin while you're dilating, or move some of the skin out of the way, some of the adipose tissue out of the way. But if you're a single doc, one hand remains on the wire. For me, it's my non-dominant hand, and it's always preventing the wire from moving as the dilator moves in. Now, further, to make sure you're not kinking, as you're dilating, if you reach any resistance whatsoever, you should stop, hold the dilator in place, and move, or as we call it, rack the wire in and out to make sure that your dilator is moving over a free wire and not a kink wire. If, on the other hand, as you're dilating, you try to move the wire in and out and it does not move, you try to pull it out and it's just a resistance, what you have done is you have already kinked the wire.
All right, as you can see, this is a perfect example of what not to do. I mean, I have no assistant holding me and the wire in the back, but this isn't one of these ultra stiff wires, and you can get away with it on an example here. One last thing that I think is just worth mentioning is that, as you can see in this video, the extra long wires make it much harder to do the dilations, because every way you go back, you have to just go back that much further, and you need an assistant that much farther back holding the wire, keeping it sterile.
Everything revolves around getting arterial access. In general, during a cardiac arrest, as the code goes on, the artery gets smaller and smaller, the femoral vein gets bigger and bigger. So getting the artery early is key, and this is going to be the difference between being able to do a percutaneous approach or having to do a cut down where it gets messy. So getting that artery is key. You need to be in the right artery. You need to be in the common femoral artery, and you need to be distal to the inguinal ligament. That's your ideal place, a couple centimeters distal to the inguinal ligament, because proximal you deal with all sorts of badness like retroperitoneal hematoma and stuff like that. If you're too distal, then you're going to be past the bifurcation point of the common femoral artery to the superficial femoral and deep profundus femoral, and that's not a great place either if you get into that SFA, because it's a much smaller caliber vessel, and you have a good chance if you're right at the junction of blowing that out, and that's a tough repair, and no one's going to be happy with that. So you want to be just a couple of centimeters distal to the inguinal ligament in the common femoral artery. How do you get there? Well, external landmarks would be the iliac crest and the pubic symphysis if you draw a line between them. And actually drawing a line for realsies with a Sharpie is not a bad idea at all. If you draw a line and then go a couple centimeters distal to that, then you should be in good shape. You could also see it on your ultrasound. If you see the point where the femoral artery goes from 1 to 2, and then you move up from that to that line you've drawn, and then go a couple centimeters down and make that the point you actually hit the vessel, you'll be in great shape.
All right, couple take-homes here. Got to make sure that you think about the wires. Think about the diameter, 0.035. Think about the stiffness, whether you want a floppy wire maybe initially and potentially using a stiff wire later on. You think about J-tip versus your straight tip, and you can develop a preference on that. You also need to think about length. Probably the ideal length is 145 centimeters for your ECMO catheters. If you buy the longer ones, you're going to have problems with sterility and just increased difficulty with dilation. Last thing, we talked with Scott, all these tips that he gave us as far as angle of entry, as far as keeping that wire straight and held onto and inside the middle of the vessel so that you know where it is at all times. So hopefully with this, you can get some tips and tricks on how to better at cannulating and how to do better wire control.